Hey everyone, you're here listening to Into the Red Zone with Ellen and Tate. What we have today is a really special guest, someone that Ellen and I have, I'm going to sound really weird, personally have a bit of a crush on, but it's okay. We have Quinn Henoch from Clinical Athlete here with us today, and we're going to be talking about athlete care and support. I guess, Quinn, why don't you start off telling us a little bit about yourself?
Sure. Well, first of all, thanks for having me on. I really appreciate it. I am a physical therapist, or as the rest of the world says, a physiotherapist. I think that sounds a little bit cooler. So we'll call myself a physio. I'm a physio in the United States. I'm in California, Southern California, and I have an office inside of a gym, and it's kind of a specialized barbell sport gym, mostly the sport of weightlifting, the snatch and clean and jerk. But my office is inside of that facility. I open the doors, and I've got this playground of weightlifting as kind of the rest of my clinic extended. So it's a really cool environment, and it's exactly where I'd want to be as a practicing clinician. And before that, I was a strength and conditioning coach. That was kind of my background before anything physio. It was strength and conditioning, and I worked as a coach and a performance coach, sports performance, whatever they want to call it these days, all of that stuff at lots of different facilities until I decided that I wanted to kind of expand my horizons a bit. And I guess I missed school, and I got tired of being an adult after a year and a half. And so I went back to physical therapy school and got my degree there. But I've still kind of kept my lens and bias kind of in the strength and conditioning world, because the principles are largely the same, which I'm sure, we'll get into a little bit. But other than that, I played American football in university, and after I had graduated, I started competing in the sport of weightlifting, and have been doing that for the past 10 or 11 years exclusively. So that's been kind of my journey as a mediocre athlete, and mixing my physio and all that stuff kind of within, and that's been kind of the whatever content or anything that I put out there has kind of been the mix of all of those experiences. So it's been a fun journey.
I'm just going to pull you up for a second, Quinn. I don't think you're a mediocre athlete. Let's just check that a little bit, right?
It's all relative.
I don't hear your relative. Yeah.
Relative to the Olympics, maybe, but
Yeah.
Well,
Yeah.
I have high standards. Damn it.
Tate can relate to this. What's Tate's like? What is your ideal numbers that you keep comparing yourself to, which is ridiculous?
I don't see why I shouldn't be doing a 10 times bodyweight total in powerlifting. I need to be doing it. I need to do it right now. And then weightlifting as well. I'm starting weightlifting after the States.
There you go. Work hard. You'll get there. No doubt.
Yeah. Yeah. Basically,
Without a doubt.
Yeah. Well,
Yes.
Even if he doesn't right now, we're going to take drugs at like 60. So it will happen at some point.
Get in on this. Jared's in on it. I'm pretty sure John's in on it. At 60, we're all getting on everything.
On any drug possible, basically, to just max out in all of our lifts.
Well, I'm masters lifting starts at age 35, and I'm 34. So really, I'm just holding the line until literally overnight I jump a level and become national and international level weightlifter, like podium level. And I'll just leave out the fact that it's masters. Not that that's not, also a feat, but we're just waiting for that day. We're surviving both in life and in the gym for that period of time. Yep.
And then at 60, getting on the gear with us. All right, sweet, awesome, cool.
The issue with that is, can you just imagine, like, oh, Quinn Henoch gets popped for PEDs. Like, what was he lifting? Like the worst performance enhancing drugs. If you're gonna get popped for drugs, you have to be a little bit better than I am. You have to earn the right, I guess.
Quinn, I think you've earned the right at the age of 60 to do whatever you want.
Well, how do you know I'm not on drugs now?
Because I know that I feel like you're the kind of person that if you were on drugs, you would probably say it. I feel like you're a kind of honest guy. I'm trusting you.
Whatever, that's fine.
Yeah. There are YouTube channels of people like that. So it's definitely a thing.
It's the next like lucrative stream. Who knows?
Yeah.
Yeah.
Let's go down the clinical athlete doping sector now.
It also is illegal. So I think I would just be paranoid of the cops like kicking my door down. I don't know. We'll see. We'll have to we'll talk about it.
They got bigger fish to fry.
I haven't thought this through.
Well,
we're having a meeting after this.
Yeah,
we're having a meeting after
your
this.
Your takeaways can be like, okay, I've really got to think about this now.
Yeah.
Like, where if I'm going to take drugs when I'm 60, that's what I'm walking away from this conversation with. This conversation is already
we need
going.
to pull this in. Yeah, we need to pull this in. I'm sorry, Quinn. I'm really sorry, mate. I got really carried away. I'm just really excited to have you on. Now, I really like the fact that you got this cool little office and it's in a gym. It's kind of like my life. In fact, I don't even have an office. I just work on the gym floor. So I'm feeling this vibe. I'm like with this. Anyway, let's get to the first question, I guess, because that's kind of what we all hear about is athlete care and support. So I guess, first question being, are injuries inevitable for athletes, and what can we do to decrease the risk if there is the chance for that?
Yeah, those are big questions. They're good questions. And, decades of people's work and research kind of go into these types of things. But are injuries inevitable for athletes? It's like yes or no, yes and no. I don't want to say that they are inevitable because there are likely people who have trained hard and really, it all kind of depends on how we define an injury. And that's one of the big issues as well. And I don't want to get too pedantic on that, but it does matter in these conversations, what is an injury exactly? I mean, does that mean that something literally snapped, crackled, or popped and you can no longer use that thing unless it gets reattached? Or is it you had a little niggle that you asked your coach about, or you asked the athletic trainer about, but nothing actually changed? But the fact that you asked somebody's advice about the thing that's different is now that constitutes an injury. Because when you look at all the literature, that's one of the issues is everybody defines injury differently. And I know I'm getting far afield from the original question, but that's what makes these conversations so difficult in the first place, is just even defining our terms. It's really, really hard. But if we're just going to broadly define injury as some type of non-normal pain experience, you're going to be hard pressed to find somebody who's pushing performance boundaries, who's not going to experience something like that along the line. And it's also a conversation of the fact that high performance and pushing for sport adaptation and health and longevity are not linearly correlated. They're many times inversely correlated. So the harder you push your performance boundaries, you are, by definition, increasing your risk, because you are exposing yourself to higher and higher loads that you've not done before. You're doing that on purpose so that you can become more fit, but that just showing up and doing that increases your risk. And so that you have this paradox of, I want to maximize performance, but I also want to decrease risk. It's kind of an oxymoron. And so it surprises people then now to the second part of your question, when I actually tend to spin things from a performance perspective. So I tend to reverse engineer from performance goals. And if pain and injury are a constraint that we're managing in the process, then so be it. But it's where do you actually want to get to from a performance perspective? And managing pain and injury is within that process, but it's not, I don't have a separate injury reduction program. It's all meant to boost your performance. And I think there's like risk that's inherent with high performance. And there's also maybe unnecessary risk where, like, if you just do 100 reps of a thing every single day, like there's things that you could do that are probably giving you a lot more negative than positive return. But that's just like regular strength and conditioning principles, like just programming stuff. That's not special to rehab. So my lens is performance based. It's pain and injury are not separate constructs. They set boundaries sometimes and constraints in the process. And we manage those things, and we try to increase the bandwidth for the athlete over time. And then we go from there. So are injuries inevitable? I won't say inevitable, because that's kind of a black and white thing. Because there'll inevitably be somebody who's like, hey, I never got hurt and I went to the Olympics, but those people are probably very, very, very rare. The chances of you running into some type of speed bump or roadblock in your training career is really high. And that's the reality of it.
Oh, sorry, Quinn. Didn't mean to cut you off.
No. I was done. It's good. You cut me off a lot. Do that, because
otherwise
the show will be better for it. Yeah.
It's okay. This is a space where you can get up on a box, pontificate as much as you like. It's totally fine. No need to apologize at all.
You could swear too as well. You
yeah, just do whatever the fuck you want.
Free space.
Yeah.
Now, hey, that's you. You swore this time. You have to put explicit on it, not because of me.
Oh, true. I'll take blame for that this time. I really like what you said there, Quinn, about injury being a constraint rather than worrying about necessarily protocols for, decreasing the risk of injury within a program. Because I don't work with athletes very often, unlike Tait and yourself, but I have this sort of perception myself that athletes aren't really told, or at least I know when I was competing at a high level in netball, for example, when I was a lot younger, and I actually was somewhat athletic.
You are athletic.
Just hang on to that. I wasn't really told about pain and injury. I wasn't really told about the likelihood that I would experience different pain. And I feel like if someone at the very start of my career was like, it is likely that you're going to be in pain at some point. It is likely you're going to feel discomfort in X, Y, Z. And this isn't necessarily bad. It just means we need to change some things. And I swear to God, if someone had actually just said that to me at the very, very start, it would have made a world of difference having that expectation and understanding. Whereas I feel like that's something that doesn't happen as much in the athletic world. Is that a correct assumption for me to have, or can you both fill me in?
Yeah, I think, gosh, one of the issues I think is just the rehab world, and like healthcare and rehab and then high performance are many times kind of separated. They're like siloed, and the professionals in each kind of butt heads a little bit. And like the healthcare and the physio world will say, oh, these strength and conditioning coaches they're crazy. They can't keep their athletes safe. And then the strength and conditioning world will say, oh, the physios, all they do is baby our athletes and they don't prepare them for anything. And they're both right sometimes. But from my perspective, our big thing in the health and rehab world, many times with athletes, is that we're constantly underloading these athletes because we're scared to injure them. It's like this weird thing where they're injured many times because they're ill prepared for the rigors of sport, but yet we don't prepare them well enough to go back to sport. And then we wonder why there's this kind of vicious cycle. So we're like so scared, like they're made of glass. But again, we have to not only in sport, push those boundaries, but in rehab as well. So I just think sometimes there are competing goals, and at the top levels of sport, you're really not looking to maximize performance, because performance is already maximized. What you're looking for is to maximize availability. You want to keep the best athletes in the world just on the field of play. And that becomes kind of a different looking scenario. Whereas most of the athletes that we work with are they're beginners or they're intermediates, and they still have a lot of room to grow in terms of making gains, from a performance perspective. So I think it really just comes down to trying to find a common ground, a common language for all the kind of the silos to agree upon. And I think if you take away all of the labels of physio or healthcare provider or coach, then we know that we're working with a human in front of us. They abide by certain physiological principles, and rehab is strength and conditioning, likely from just a different starting point. and maybe your available options are more limited as far as like entry points into what they're actually going to do from an exercise prescription standpoint. But the principles of specificity and progressive loading and these types of things are all the same. So I think if we can just look at things from more of a common lens, that would really help. And then the athlete wouldn't hear different things from different people, because they sometimes get stuck in the middle. We forget, oh, there's actually like a human, like we're not the most important piece of this. It's the, like, I wouldn't have a job if it wasn't for the patients and the athletes, and neither would a coach. So we forget that sometimes and we make it about us. But it's like, if the strength and conditioning coach and the healthcare provider are all on the same page, it's just such a better environment for the athlete. And I think that would take care of a lot of this. And I don't know if that's a direct answer to your question, but it's more of like kind of a foundation that I think we should strive for.
No, I actually really like that foundation. Tait, do you want to speak to that a little bit more as well? Because I know you have similar feelings to what Quinn's just said.
So, I mean, this kind of, I think this kind of really answers the third question we're going to have, which was, what are the biggest mistakes allied health are making with injured athletes? And I think that particularly with strength-based sports like powerlifting, weightlifting, strongman, that kind of stuff, I think because most injuries tend to not be things like, usually it's sort of some sort of experience of pain that's stopping them from participating. It tends to not be ACL tears and there's the occasional bicep rupture and bits and pieces, but it tends to be these experiences of pain that are blocking participation. And the biggest issue I see is very much that communication, what you're talking about between practitioner, coach, and then there's the athlete, and the same message needing to be sent, which is like, you're okay, we need to modify for now, we'll push on, like very much the same messages. It's super important, because otherwise the athlete gets confused and either the coach gets in trouble or the allied health professional gets in trouble, and then we're all sort of a mess. It's probably kind of a simple way I like to do it, and that's how I like to work itself. You know what I mean? There's you might want to try something that the coach has already tried and might have tried for a long time and nothing and the athlete doesn't want to do it. So you end up wasting a couple months, and they're like, why did you bother doing that? I didn't want to do that.
Yeah. And having like a centralized program also helps, because if the physio has got their rehab program, whatever that is, but then the strength and conditioning side of things are still doing their thing, and like nobody's actually looking at each other's program for this athlete, they're like, some things are redundant or some things are just, it's not syncing up. And so if you have better communication, you can say, okay, well, we're already doing this in the weight room, so that's taken care of. Cool. Tick that box off. And then the physio can be like, okay, well, I think that this could potentially fill in this gap. So where could this fit, in the program, not one of two programs that the athlete is kind of getting that are like separate on both on paper and in the athlete's mind. It all kind of, in an ideal world, and we're speaking, in optimal here, which is not always reality. And I totally understand that. But in ideal world, we have this comprehensive program where everybody's communicating and everybody's on the same page. And if there's changes that need to be made, everybody's on board with it. And so that the athlete's not coming to the physio and the physio saying, I don't know why you're doing that. Or the coach is saying the same thing, because that's just like, it's toxic for the athlete. They just like, what the hell, So, but you're right. And one of the problems is this whole, silly thing called pain really, really confounds things and really mucks it up, because nobody really understands what the hell that is. And you mentioned it too, like things like ACL ruptures and ankle sprains and acute hamstring pulls and shoulder dislocations. Those things, as much as they suck for the athlete, from a rehab and training perspective, they're a whole lot more straightforward, because it's like, okay, we literally had this structural thing happened. We need Mother Nature's natural healing processes. We need to just progressively load this thing. The athlete kind of understands, oh, this is like, there's going to be pain and discomfort kind of embedded within this process. Cause like, I dislocated my shoulder. So it's like, there's like this kind of expectation that it's not going to be the most comfortable scenario, especially after a surgery. So the conversations about pain are not necessarily the same as somebody who's coming in with a 5-year history of low back pain. That's what they call non-specific, meaning there was no mechanism necessarily. There's no structure to pinpoint here. There's no surgery or a tendinopathy even. We could say that tendinopathy, oh, well, your tendon is decreased in its stiffness, mechanical properties, but no athlete is coming to your office and saying, you know what, I'm here because my patellar tendon lacks mechanical stiffness. No, they say the front of my knee hurts when I jump and land and cut. So pain itself is a very confusing thing. Because when you feel it, you always think that there should be something done. And that's another thing with healthcare providers. We feel like we should always be doing something more, like giving more. So addition by addition. And in a lot of cases, it's addition by subtraction. And the more that I can simplify the program, especially from a rehab standpoint, because if it's an athlete, competitive athlete, they're already doing a lot of stuff, usually, a lot of different kinds of stuff. And so if I can keep my program as simple as possible to complement what they're already doing, that tends to work a lot better than just always chasing the pain. Because I mean, if it's the front of the knee today, it's the back of the knee tomorrow, and it's the side of the knee next week, and you know what? It's the other side 2 weeks from now, and so you're always like feeling like you're chasing ghosts. When really it's again one of those things where the pain experience is more of a thing that we manage as opposed to something that we're trying to cure. And that may sound like semantics to some people, but the semantics matter in how you frame it and the decisions that you make from a programming standpoint, and also from a communication standpoint, when you're actually speaking to the person about why you're doing what you're doing, what to expect. Promising a pain-free process is probably not the best course of action, because you can't predict that. And the first onset of pain that happens after that prediction or promise is you're going to lose a little bit of buy-in and credibility. So you have to kind of set expectations up front, that this is going to be a moving target, and feedback and communication is really important to kind of redirect the ship when needed. What was the question?
No, I think I like that. Some really nice takeaways there, and I really love the point of going. Well, sometimes it's about taking shit out, and so often I see people. Yeah. Oh yeah, like I see someone doing a 10-minute warm up before they touch a barbell. I'm like, why don't we just get rid of it? And all of a sudden they feel better, and I'm like, well,
or just take that 10 minutes and put it into more barbell warm up. Just reallocate that time to something a little bit more meaningful.
And discussing that with the coach to go, well, this is what we want to aim for. I want your input. And then the program gets written out by the coach, sent to the athlete. And then we all have the same program. We're not all looking at different pieces of paper or anything like that. And I froth on that. And I was wondering, Ellen.
I was really hopeful that you weren't going to say froth today.
Okay, well, I can't help it. I get too excited. But I was wondering, Ellen, I know that you haven't worked with athletes, but I'm assuming you've worked with people that have had personal trainers and stuff like that, and how maybe things like that have worked into how you've worked with even just general pop people that have a personal trainer.
I think that I'm going to apply this to all allied health as well, because I don't see this as being different if someone has a doctor or a physio or whatever that they're working with, or an osteo, or God forbid, a naturopath. Sorry, no shade to the naturopaths, but a little bit of shade. Sorry, it's a pseudoscience. So, but it's really important, because particularly if that person has been with that client a lot longer than you have, they have actually a lot of information about that person, And as Quinn was saying, you cannot have, whether it's an athlete or a client, you cannot have that person be receiving mixed messages from 3 different health providers, whether that's a personal trainer or an exercise physiologist or a physio or an osteo or your GP, because it just breeds a ground where the person is just completely uncertain as to how things are going to play out. And one of the things we know with pain in particular is that expectation is so important with treatment, right? Just having the expectation that something is going to be helpful or work. And how is someone supposed to have that level of buy-in or understanding with their treatment when, 5 different providers are telling them different stuff about what's happening in their body? It's actually impossible. All it breeds is more confusion, more anxiety about what's happening. And I wanted to pass this question off to both Quinn and Tait about what Quinn was saying about silos, because I found that quite interesting, how we all sort of just stay in our silo. And I wanted to know why you guys think that is. For me, I personally feel like there's a lot of ego in healthcare, and that a lot of us feel like we're top shit and that we're above everyone else. We do. I know I went through a stage of feeling that way. Like I felt like I was just better than a personal trainer because I had a fancy piece of paper on the wall or whatever. Like I went through that phase. But I've learned that me being egotistical and me thinking that I'm the best and I have all the answers has actually been a negative to some of my clients in the past, because I have not supported them in the way that they needed. I made it about me and not about them. And so I wanted to throw it to both of you, if you have any extra insight as to why you think healthcare providers sort of stay in those silos and what we can do to sort of break down that a little bit in a practical sense.
Well, I think conversations like this help. Just even talking about it, recognizing it, and people listen. But ego probably has a lot to do with it. I also think it's just part of the way the system is currently set up. I mean, in physio school, we are not trained to be specialists. We're trained to be generalists. So they tell you that day one, don't expect to specialize. You're going to get as much experience in a nursing home, in a hospital, in an orthopedic outpatient clinic as you're going to get anywhere else. So just that's the way it is. So for me, I was coming in with a background in strength and conditioning. But if I didn't, I would only have my physio degree, in which I would get very, very, and if I want to specialize in quote unquote athletics, I would have very little training in that population specifically. And as far as the exercise prescription, some of it's still just kind of a little bit, outdated, and the pink TheraBand stereotypes of physio school are still kind of true, and it's getting better. But so if somebody doesn't have that strength and conditioning background, they look at somebody throwing weights around and deadlifting with a little bit of a rounded back, or squatting where their knees are going forward past their toes, and they just are like, whoa, it looks dangerous. And it's kind of like it's kind of framed as somewhat dangerous in school. So I think it's just kind of the way that the training is. They're not integrated, and you have to, maybe your rotation or your internship, or you're integrated into a strength conditioning, or you put it upon yourself on the weekends to go like shadow strength conditioning coaches. And like, that's what I tell people to do. Students ask me, what books should I read to learn more about strength conditioning? I say, yeah, well, here's a book, but what you should actually do is go learn from somebody in person, and actually like immerse yourself in the environment, so you really get a feel for what that's like. So I think there's just not enough of that. So we're already like put in our silos from an educational standpoint, and it's just easy to stay there. And the longer we stay there, the more we kind of dig our heels into the ground, and those lines get, delineated more and more. So it's kind of a system thing. There's egos everywhere. And it's really, from a practical standpoint and how to fix that, I really think it's stuff like this, and different communities, and the select few that can like pull their egos down just enough to have a conversation. As crazy as that sounds.
No, sorry.
Please, no, Ellen,
are you
please.
sure? Okay,
yeah,
sorry.
Please, yeah.
No, I totally agree. And I really resonate very highly with what you said about like strength and conditioning principles, because I was a PT for, I think I mentioned this, I was PT for 4 years before I finished my EP degree. And the only reason I knew about strength and conditioning principles was because I was into training and because I'd stumbled across different stuff, as I said to you, like Juggernaut training system stuff, and they had like very in detailed stuff about training principles and applying them and all that kind of stuff. And that was the only reason I knew some of that stuff. University provided me with nothing that was related to strength and conditioning principles. Zero, like literally zero. Never had even a lecture on it, let alone any practical. And I know that's slowly changing. I know that my university has actually built a strength and conditioning gym into their university, which is pretty dope. And that they're going to have, it is, and they're going to have an actual subject dedicated to strength and conditioning. So I think you're right. I think things are finally starting to change. But for everyone else who went through university and they never got exposed to that, they didn't have the background that I had, they weren't given the opportunity to explore that side of things because they didn't have access to that knowledge. And then if they go and put themselves in an environment where everyone around them and their context solidifies that knowledge, you know, how are they supposed to be able to explore those concepts and ideas in a free way?
Exactly. But there are opportunities, and just making people aware of that.
You cutting in, Tate? If you're cutting in, you got to just commit to it.
I totally wanted to just, I know, but I don't want to I'm trying to overshadow the big boy Quinn down there. Like, I don't want to have to be outflexed. I don't want that to happen. So I totally, so much of what you guys say, you know, my own experiences, bits and pieces. I think that within the system, when sort of Quinn's talking about is there's almost like a hierarchical system, you know what I mean? With some people at the top, some people at the bottom. And I've kind of felt that being an EP where, because I only do exercise, I only use exercise to treat people, that I'm at the bottom. It means I have less tools in the box. That means puts me at the bottom, right? And I've sort of always felt like when talking to physiotherapists and chiropractors and osteopaths, they're like, oh no, this is the treatment path that you're going to go with when you exercise with this person. I'm like, don't fucking tell me how to do my job.
Right.
Like, I know what I'm fucking doing. Like, this is you did nothing of exercise at university. You're telling me how I should do this with a person. I think everyone's on the same fucking level. I know that when I started, I certainly thought I'm an EP. I'm way better than a personal trainer or a strength coach. The reality was that the more I learned, the more I realized that there are strength coaches and personal trainers out there that knew so much more than I did. And I needed to start to listen to them. You know, that's the kind of the part where it doesn't really, we should just all be on the same level and all be talking the same language and be really respectful about it. Instead of creating this sort of, these camps and silos, as Quinn kind of puts it almost as well. Like,
well, I think the respect is the important piece, because we should respect each other, and we should also understand where our skill sets are. So hierarchy, if it's a hierarchy of power, is kind of what we're getting at, almost like a whatever, I have the higher degree, so what I say goes. From, let's just say, from an exercise standpoint, well, in that case, you know, it'll be a physician who, by and large, don't really have any knowledge of exercise. They keep people alive, which is also very important. So, like, if we're all understanding of each other's roles, I refer out to people all the time because it's out of my skill set. It's out of my scope, not even just from a legal standpoint. If I think this is some type of disease state that's not within the scope of physical rehab, I'm going to refer out because that's out of my skill set. If somebody considers that a hierarchy, so be it, but I'm respecting my skill set. I'm respecting somebody else's skill set. And I would expect that to be reciprocated. I would expect the physician to understand enough about exercise to know that this person needs progressive exercise, and a physical therapist or an exercise specialist, that's what they do. So that's who they're going to refer to, and they're going to allow the expert to work within their skill set and work within their scope. But I mean, you're right. In the real world, a lot of times the healthcare professionals will take this kind of I'm the doctor approach, and just not have a conversation, which is unfortunate. But, you know, it can work both ways. So I think we always say like change happens one funeral at a time. So like the old guard.
Jesus Christ.
Well, I mean, so just think about it. It's true. The younger you are, the more you're apt to kind of have conversations and be open and these types of things. But I digress. I think we're
Sorry.
identifying. Yeah. There's some people they're kind of set, you know, if they're, change is hard and belief change is hard and like those types of things. So sometimes you just deal with people and you're like, you know what, that they think the way they think. And if I don't want to work with them, then I just won't work with them. And so you kind of make that delineation as you go. But yeah, you're right, Tate. I think being on the same level from a respect standpoint, but level is maybe like, again, going back to the hierarchy, but we should kind of recognize our skill sets. And physio and strength and conditioning, you know, the physio doesn't have to be able to manage a full-on year-round strength and conditioning program. And the strength and conditioning coach doesn't have to know how to manage the first 12 weeks of ACL rehab from start to finish, you know, but they should know enough about the two worlds to have a conversation, because those worlds are very closely linked. From like a physician, from a surgeon disease state standpoint, I need to know enough to say, this is not what I can treat. And I also need to know enough to say exercise could potentially be affected by this, or this could affect tolerance to exercise, and then be able to have a conversation about that. But to know the ins and outs of the disease state, you know, could just be like cool knowledge that it's not going to actually be useful for me. So the lines are blurred, but it's still kind of this spectrum where you're turning the dial a little bit. And as you go to the end of like treatment for whatever crazy disease state, you know, is going to be like physician land mostly. But then as you go back to physio land, the lines start to get blurry a little bit. And then you skew all the way to whatever. I have my athlete on a force plate testing their, you know, weight shifting from side to side during a back squat or something like that, where the physician's like, okay, cool. You know, tell me the outcome. I don't need to know how to run your force plate software, or whatever the fuck we're talking about. You know what I mean? So it's like, understanding our lanes. I hate the word lanes, but they don't have to be like barbed wire guide rails on each side of the street. It just has to be like, this is where I can take it. You know, this is where you can take it. And we have this common meetup point, like the truck stop where all the highways kind of converge, and then we can audit the program. Because I was thinking when we were talking earlier about addition by subtraction and stuff, I don't think it's the exercise or like the program itself, because I mean, most programs aren't that special. Like they all probably kind of look the same, like a weightlifting program. Everybody's quote unquote system, like, you know what, they're going to squat, they're going to pull, they're going to snatch, they're going to clean jerk. Powerlifting programs look largely the same, but a lot of it's just kind of looking within the program and seeing what changes you can make. Like I have an athlete who has some anterior knee pain and is wanting to like be able to do more jumps and power and explosive stuff like that. And we had a warm up of like goblet squats and wall sit, like single leg wall sit, and some type of like snap down exercise where they just do basically like jumping down into place and stopping. But his knees were still hurting when he would go to actual jumps. And so his question was, what can we do? You know, like what else can we do to prepare for jumps? Cause it's like, I'm still having problems. And I'm looking at the stuff that we're already doing. And it's like, well, it's like this, we're doing it. But then I'm like, maybe the intent is not there. So what I told him was, during your single leg wall sit, I don't want you to just create the amount of muscular tension that's required to just hold the position for the allotted time. I want you to actually create your own muscular tension on top of what you need to just hold the position. So the intent needs to change. Push harder into the floor, more force into the ground. And then I told him on the goblet squats, I want you to, instead of just smoothly going up and down, which is what he was doing, I want you to go fast on the way down and stop and have to absorb all that load and then quickly change direction. So kind of like mimicking a counter movement. So the exercise didn't change, but the intent changed. And then his report was like, I felt way more prepared for my jumps. So the the feedback system is the important thing. The communication is the important thing. Because if I was just looking at the program on paper and he was saying, oh, knee pain, continue, 4 out of 10, 4 out of 10, I'd be like, okay, we need to switch up the exercises. But if I actually have a conversation, that's my kind of my feedback system, my feedback loop. And I get what I think may be happening. Sometimes things don't have to change. So from an exercise standpoint, like there's so many exercises that do the same thing. I just think that's probably another thing that needs to change in our profession, is thinking that we have the magic exercises and it's our program that's different or special somehow. And it's not. You go on YouTube and you can find 200 exercises to fill the bucket of whatever the heck you're trying to get the person to do. So the beauty of it is like the feedback loop and the communication. And I guess that's what they would call the art, quote unquote, is you have all the toys and the sandbox, and it's just kind of how you put it together. But it's just keeping things simple. And then that way the conversations for whatever other stakeholder is a part of it, be it an exercise specialist, a coach, the sport coach, you can have conversations that are more down to earth and, make a little bit more sense across the board. And I think that helps too.
That really, I think this really leads well into our next question. And that's about where a lot of allied health get fixated on sort of one model of practice, whether that be some of the acronym camps of FMS and SFMA and DNS and PRI and FI, all that kind of jazz. And they all sort of have this thing of like corrective breathing or infant patterning or pathologizing certain positions or movements. And I guess what is the cost or benefit of introducing an athlete to these models?
Well, I mean, there's a quote from a statistician named George Box, and his quote is, all models are wrong, but some are useful. So when we say like model, what that means is we're trying to create some type of meaning to the world. Essentially, we're modeling the world because it's too complex and we're trying to make sense of things. So these exercise or these movement systems or models are just trying to make sense of things. So I don't fault, so a model is wrong. They're all wrong. And so then that's why I kind of subscribe to this concept of model pluralism, where, well, if all models are wrong, why would I only subscribe to one? I would kind of make my own mental model from all of these models and kind of create my own mental model of the world. But then you need to have checks and balances too. So checks and balances could just be having a group of colleagues who are not going to just be an echo chamber for you, but are going to kind of like call you on some stuff. Checks and balances could also be the athlete and different KPIs or key performance indicators that allow you to know if things are going in the right direction. Like if all you're doing is corrective breathing and infant patterning, like developmental positions, and your only metric of success is the athlete's telling you, yeah, it feels easier for me to do this 90-90 breathing exercise with a reach. It feels better. Well, okay, sweet. Like, what does that mean? Does that transfer to the meaningful task? Because they're probably not trying to win the medal in 90-90 breathing. So you need to have something beyond that that's more of a universal principle. If it's an FMS corrective, fine. Whatever it is. Honestly, like at this point, poo-pooing on different models is I don't think all that constructive. It's pulling back and saying, okay, what common ground can we say is moving the needle forward? Like, I don't care if you're just getting good at 90-90 breathing. Like, what's the transfer there? Because we all will agree that the meaningful activity for this person is probably something else beyond that. So we need to have other measurables that can be taken away from the model and measured independently to kind of know if whatever we are using is having the desired effect. So I think there's cost in only subscribing to one. And I think from the clinician standpoint, it really just boxes them in. It makes it really hard to have a conversation because most of these things are expensive to learn anyway. So you have that kind of sunk cost fallacy where, if you spend a couple grand on these courses, you better believe that that you're going to be looking through that lens, because like, why the hell did you spend all that money if not? And I am saying these things because I have gone through these processes and I continue to do so. I get excited about things that I just learned. It's that recency bias, and that, sure enough, that's what I'm doing until the excitement kind of wears off and you slide back to the middle. But you might take bits and pieces of what you learned with you, and so I think we're better for it. I just think if you can take all of them, go ahead and take all of them. It's just that because that would be a really expensive endeavor, maybe we agree on principles that are not necessarily system or model based first. And then that way you can take these courses and then compare them to your kind of like your foundational principles, instead of the model itself becoming your foundational principle and then comparing everything to that. Because it's hard to step out of that bubble once that's the only thing that you're stepped into. And it'll usually be the first one that you go to is the one that you latch onto first, or the first one that you like. Like let's say if you go to FMS and PRI and SFMA or DNS, it'll be like, oh, I just really jived with DNS for some reason, so I like that one. There's usually not a good reason other than one of the exercises felt good, or you really liked the instructor or something like that. So again, the athlete, this is why if you go to 10 different physios and you're an athlete, you're likely going to get 10 different treatment approaches and models. There's not really a standard operating procedure. And so if you're the 11th PT, you've got this athlete now who's had so many things told to them, and you're likely going to tell them something different. So like, why should they listen to you? It's really difficult. So that's why I try not to, especially in the meeting with the athlete, try not to poo-poo on anything they've learned in the past, because I don't think that works very well on the first encounter. You're trying to build a rapport, and what if they liked whoever the PT was prior, they just couldn't see him, they moved or something like that. So what I try to say is things like, okay, you tried those things and you told me like, here's what kind of worked well, here's what didn't. I think what we can try is XYZ, potentially what was missing in all of this. Like, so you're kind of meeting them in the middle. And that's really what happens with all of these different models. Also, they're all going to kind of fall short somewhere. And you say, okay, what can I take from this? And what doesn't kind of pass maybe it's a BS meter or whatever you call it, whatever your comparison is, or the group think, a bunch of the colleagues that I respect, seems to be a consensus that this model doesn't jive with them. Then maybe that raises a flag, and you can dig into the why, within your colleagues. Like, what is it about this model that you guys don't like? That can help too. So I'll stop there. But bottom line is, I don't have a mental model that's any more right than anything else. And so my stance at this point is to not necessarily just totally discount any of these systems, but to also recognize that since they're all wrong to varying degrees, that it's probably good to just stay open, and have some type of anchor that's beyond them to base your decisions and knowledge on, if that makes sense.
No, it makes a lot of sense. And I really like what you said about, supporting your athletes or your clients in spite of what they might think or feel, even if it's not the most evidence informed way of thinking. Like you were saying, say they really love FMS corrective exercises because that's what they experienced with their last PT. And so they brought that to you and they're really excited about it. Like, yeah, I really like this stuff. And instead of dismissing it, just going, okay, let's do some, what do you think could be added, or what do you think's missing from this piece of the puzzle, or what do you think you haven't tried? What do you think you might need to start feeling better apart from this other stuff? And adding that missing piece of the puzzle for them, And I've found personally, again, I don't work with athletes that much, but I'm assuming it's the same because funnily enough, athletes are just people, eh?
They just lift more sometimes.
I often find that if you don't touch that other stuff and you don't poo-poo it, like Quinn said, and you don't shit on it, often they naturally start, not doing less of it anyway. You might check in with them about if they're doing it as their home exercises, for example. You might start checking in with them about whether they're doing it or not, and you might notice that they're starting to do it less. And you haven't actually said anything to them about it. They've just naturally started to do it less. And if they continue to do it and they love it, who cares? Like, it doesn't really matter in the end. If you have the other pieces of the puzzle, and it's better for them to feel supported than for you to lose your therapeutic relationship with them early by shitting on something that they think is valuable.
Yeah, because you have leverage in that situation. I mean, first of all, they're coming to clearly, if all of the things that they were doing was the solution, they wouldn't be in front of you. And right. Yeah, exactly. So like we wouldn't be in a scenario. So that's not something that has to be said in that way, but that's implicit leverage that you have in the situation as the person that they're coming to give the next, to push this beyond where they're able to put it with whatever they've been doing. And then secondly, a lot of things can be framed that they understand. It doesn't have, it's like, okay, you've got these lists of things that you do. Those are fine. Like if it's a list of FMS correctives or something like that, they do it 3 times a week. I say, that's fine. Here's what I think we can build upon. This is what I think is missing. It's not getting us to here. And you kind of reverse engineer because those aren't your goals, right? You're not trying to win the gold medal in quadruped thoracic rotation or insert favorite FMS corrective. And I was FMS.
Or Indian clubs.
Yeah, whatever. Exactly. Whatever it is. Like there's so many things that fall into the bucket of just like, a cool like movement's probably good for warm-ups and like gets you going and moves your body, which is good. It's just not specific and progressive enough to measure and to create kind of like continued progress. So you just hit a ceiling with that stuff. And this is a conversation that I will have. I'll say these things. Those exercises are great. But let me ask you, are they working the way that they used to work? And a lot of times the athletes will say, well, no, like I'm keeping it up, but they, it's like you kind of lose that novelty effect. You lose that effect of the exercise. And that's with anything. We don't do the same training program forever, no matter what the exercises are. So when you start framing it like, okay, cool. So like the next step to get where you want to go, because you named your goals. Your goals are there's a big gap between whatever your goal activity is and this current set of exercises. So I think what I can bring to the table is how to bridge that gap. And I think what we're missing is X, Y, Z. And then you can go into the specifics and you can say like, you can keep doing this stuff. Like that can be kind of like a little baseline for you. If it's part of your routine, I have no problem with that. But to take the next step, here are our options. And here's what I'm going to recommend. And that I can't think of a situation where an athlete has said, that sounds like bullshit. I'm just going to keep doing exactly what I'm doing. Like it's unreasonable what you just said. But I'll tell you where you will have problems and where I have had problems in the past is to say those exercises don't work. And here's why they don't. And you, again, like who are you doing this for? The athlete in front of you? No, probably not. You're doing it to feed your own ego, to make yourself sound right and smart, right? Because you're the doctor. But you're right, Ellen. I find the same thing. Like they figure it out on their own to just start trimming the fat a little bit. It's the same with foam rolling and all these other things that I still get annoyed to the same degree on, but I'm much less trying to just rip them away from everyone. Because it's just counterproductive. As long as they're ticking the boxes off of what we want, like what we kind of decided is going to be that next step, that I'm happy as a clinician. And I don't have to change their beliefs on everything either. Really, like people know I don't provide manual therapy in the traditional sense because I feel that there's an opportunity cost to that. And what I mean by that is the time that you spend doing something is obviously time that you can't spend doing something else. And so when I'm performing manual therapy, I'm looking at the clock and I'm like, geez, like I still want to like go over the program with them. I still want to look at these movements. I still want to like test XYZ. Like, what am I doing right now that is providing some type of benefit that I can't get? And so I don't do that anymore. But that's not to say that if an athlete wants that I don't send them to somebody who does those things probably better than me in an environment that's more conducive to it. Like my table's not very comfortable. The lights in my office are kind of bright. Like it's not a relaxing environment necessarily. So it's like, here is a massage therapist that I know really well, or here's a clinician. If you want these things, you can go to this person for them, but you have to understand what those things are probably going to provide and what they're not going to provide. And if you're going to be working with me, these are my recommendations on what to work on. Because again, I'm leveraging the fact that they're coming to see me, and I'm being respectful of their beliefs and kind of the patient expectations, but that doesn't make me budge necessarily on what I'm ultimately going to provide and not provide. So there's safe boundaries, and it's their decision. And that's the informed consent process. And I think if more clinicians felt, take the process that way, you feel less pressure to quote unquote fix this person. You give them the options that are available, all the way from doing nothing and letting, just the wait and see approach, which is sometimes viable and less expensive and probably as effective, all the way to like just throw in the kitchen sink of all the modalities that you can think of, with anything in between to be exercise included. You lay out the options. The clinician gives their interpretation of best evidence and probability of success based on, which treatment strategy we go for. And then you let the patient decide, and it's a shared decision-making process. And I think that mindset shift for me alone has increased my career by 10 years, like just from a burnout standpoint, not feeling like I have this pressure, because you feel pressured to fix people. And and then when they don't get better, like you're like, what is wrong with me as a PT? Like, what am I doing? And like, they're getting frustrated, and I don't know where to go. And so, yeah, we were, the original question was like FMS. It was systems and mod.
I love it. This is like,
Talk.
My bad.
With not to poo-poo on what you were saying, Quinn, because I totally and absolutely agree. There's always something to take away from these courses, despite whether they're right or wrong. And most of the time I've felt, because I've done all of them, right? I'm a course junkie. Can't get enough. Get it into my veins. Just inject it into my brain. Now, the part is you can always take something away. And I find some of their crazy, weird exercises can be really cool just to focus someone's attention on something else, and they feel better. Cool. Irrelevant. But what Ellen was saying was very much like, if someone likes something, don't take that away from them, because it's a really quick way to get them to not like you. And as Jared has said in another podcast, was make sure that person fucking likes you. That rapport is really important. Yeah, be a likable person. Don't be a dick. Don't tell them they're wrong or force something down their throat that they don't want or don't want to hear about. Like you got to be a likable person, and each person is different, absolutely. But if they come in and they say, yeah, man, I kind of liked this exercise, I'm always like, yeah, cool, keep doing it. That's fine. Can I give you something else that might be relatable to your warm up that might feel really good though? Oh yeah, cool, awesome, yeah, fantastic, great. You just kind of, I don't want to hear about it too much because it drives me a little bit crazy, because I've been there, done all of it, but I'll still accept them for what they like, and I'll try to progress them to something that's far more relevant. Oh.
No, I mean, I think these conversations are just going to be the never ending. Like, there's no right or wrong. We've got a thread in the clinical athlete forum right now about like giving manual therapy as a way to get buy-in, so that you can eventually so that you can keep them around, so you can help them like eventually. Like, so if you piss somebody off or you don't give them what they want and they just leave, when you could have treaded a little bit more lightly and kind of, dangled the carrot just enough to have enough conversations over time to get them to do things that you think are more evidence-based. Like, I don't know if there's a right or wrong to those arguments on either side. Like drawing a hard line versus, saying, well, if you feel like you have to like give them a little bit of whatever you don't think is effective, well, your communication skills are just bad. So there's valid arguments on either side. I do think there is a way to just be, to set boundaries as a professional. Like this is what this is, and this is what I don't provide, but here are the reasons that I don't provide it. And here's where I think I can help you. And I think those conversations can be like, they can be healthy and respectful enough where the person can understand. And if they want to continue to see you for these things and they feel that that is valuable, they will. And if they're just not ready for that and they're not ready to listen, so be it. But you got to feel like you can't help. Not everybody is in the frame of mind and the time in their life to be helped in the way that you can help them. And that's another thing that I've kind of learned over my course of my career is I'm not right for everyone, and vice versa. And there have been times where people have come back and said, you know, what we talked about, like, I want to try that now. Awesome. You know, and so I don't know, like that's a skill to just have over time of when to say, you know what, you know, we're not a good fit, but I want to help you. And so maybe this is the direction that we can go but totally another topic.
Part 2.
For another podcast.
Yeah, for another podcast.
Yeah,
Part 2
podcast
and get you
with
back
Quinn.
on.
There you go.
Yeah.
Yes.
Yeah.
Yes, please.
I think that
We better. Oh,
I'm going to just say one quick thing before we wrap this up because we are getting
go
to
for
time
it.
limit.
Go for it. Yeah.
The way that I take what Quinn is saying, and I don't also agree that I don't think there's anything wrong with having hard set boundaries where this is what I view ethically as being where my limit is as a practitioner, and this is where mine is, or whatever. And I don't think anyone is better or worse for having their line in the sand at a different point to someone else's line in the sand. I don't think that's an issue at all. I do think that what Quinn is describing is almost like what I would view as being neutral on certain things, where it's like this person is bringing this stuff to you, and instead of you placing all of your thoughts and feelings on it, you're just helping them sift through it. Rather than, you know, being like, this is bad or this is good or whatever, you're being a neutral person, helping them sift through their own thoughts and feelings about certain things. You know, I have a intake questionnaire that I send people before I see them. And it's like 5 very simple questions. It's like, why are you seeking an exercise physiologist? What's your primary concern? Why is this a concern to you right now? What do you think we need to do to start feeling better now? And what are your expectations? And just in that little glance, you can see all of those things already, like that little picture of what that person is, and you know what's important to them and what they're hanging on to and what's worked for them. And you already have that insight before you even go in to see them. So you already know what you're walking into. And I find that's very helpful because it allows for you to feel prepared and also be able to be that neutral arbiter almost of their thoughts and feelings without getting too invested in it.
Really lovely said there, Ellen. We're going to have to wrap this bad boy up. And I want Quinn to come back as well so I can hang out with him more, because I'm that kind of dude.
He's just trying to replace me slowly but surely.
Oh, wow.
Definitely. No, not even slightly. I want the 3 of us to be the best. And then we get John on and we get Jared on. And then there's 5 of us. That sounds so nice. Okay, I'm a loser. It's all right. You can also, I'm a loser. It's cool, man.
Outro, Tate,
I just get really
outro, quickly.
Yeah, outro. Okay, awesome. Some awesome takeaways there from today. A bit about, you know, injuries, pain. What is it? What does it mean to each person? Is it inevitable? Is it not? Some of the things on improving ourselves as allied health in terms of one of the big sort of things is making sure we're all sending the same message with coaches and bits and pieces, and then talking about, you know, not poo-pooing on these acronym models and bits and pieces, that more about being supportive to clients. If they like it, it's cool, it's not hurting them. Quinn, thank you so much for coming on for today. It has been definitely a dream come true for Ellen and I.
God damn it. You make me sound so lame.
Yeah, it's all right. Yeah, I sound lame. Quinn, if anyone wants to contact you about today or just wanted some sick information about you and everything the clinical athlete does, where can they find you?
Well, first of all, I hope you guys have bigger aspirations and dreams than me, than anything that involves me. And I'm sorry if that's the limit. Sorry for you. But also, if you listen back to this show and you're like, good Lord, like he made about a 0.5% of sense. I will be happy to come back on and try to formulate my thoughts better. But I appreciate you having me. I had a lot of fun. It was a great conversation. I can be found on your social media, common social media channels, Quinn.Henoch DPT on Instagram. You can just search my name on Facebook, Quinn Henoch, and Clinical Athlete, all channels, Instagram, clinicalathlete.com. The CALU, CALU Facebook group, I would encourage people to join that. It's free, and it's the collaboration between Clinical Athlete and the Level Up Initiative. And the Facebook group is just really awesome. I mean, the discussions are great, but we also do free like online journal clubs, live events like that, case studies. I'll be doing one of those soon, and just really fun stuff. So yeah, those are good spots.
Cool. And the
Awesome.
Clinical Athlete also has their own podcast, guys. So if you want to be even more confused by Quinn's ramblings, you can find him rambling away there as well.
That's it.
And listen to Jared's very calming voice.
It's a very calming voice.
Jared is the glue. Yeah, he's the glue. That's for sure.
Yeah, that's cute.
If you want to find me, you can find me at ellen.masson_EP. I also have a TikTok, guys. I finally went and took the TikTok plunge. Same handle if you want to find me there as well, but also don't, because it's a bit embarrassing. So I'll leave that with you. And you can find Tait at Total Body Benefit on Instagram if you want to harass him. Thank you so much, everyone, for listening today. We will hopefully hear from you if you have any questions about the podcast, and tune in for the next episode. Rate and review 5 stars.
5 stars. Coming for you. I'm coming for you.
Tait will get angry at you if you do not leave us a review. Take care, and we'll see you in the next episode. Bye.
See ya.